Thank you very much, Professor Ma, Professor Wang, and Professor Fan. Ladies and gentlemen, it is my great pleasure to join the CSC KSC joint session. This is my disclosure information. Okay. Historically, there are two major theories explaining the maintenance mechanism of fibrillation. Number one is multiple wavelength hypothesis. It suggests continuous wave breakout the engine of fibrillation. Number two is focal source hypothesis, asserts there is a fibrillatory source somewhere in the heart, and its fibrillator conduction maintains fibrillation. Okay, let's start multiple wavelength hypothesis first. Cigarette smoke appears turbulence and the airflow at first, but at some point it becomes disorganized, losing its shape, and this is wave break phenomenon. At the beginning of ventricular fibrillation or atrial fibrillation, they always start with several regular beats of tachycardia, then break up to the disorganized fibrillation. The multiple wavelength hypothesis was suggested as the mechanism of atrial fibrillation by analyzing computational modeling by Goldenmore in 1964. He reported that the atrial fibrillation takes place in a non-homogeneous excitable media with certain amount mass depending on the refractory period and conduction velocity. So it was already reported 60 years ago that the critical mass, refractory period, and conduction velocity, these three components are cardinal to maintaining the fibrillatory reentries. In 1973, Alessi found the critical number of 4 to 6 wavelets to maintain atrial fibrillation in canine model. And in 1991, Jimmy Cox tried to reduce the number of multiple wavelets by cut and sew maze operation to prevent AF maintenance based on Alessi's proof. As Goldenmore suggested, wavelengths and critical mass are the cardinal components of fibrillation. Wavelength is refractory period multiplied by conduction velocity, so fibrillation is easily maintained in the condition with a shorter ERP and slower conduction velocity. On the other hand, a certain amount of a myocardial mass is essential to maintaining the reentries. As reducing the critical mass in this isolated RB swine model, fibrillation changed to tachycardia and eventually terminated as cutting down the size of myocardial mass. This is a formula for the fibrillator number reflecting critical mass and the wavelengths. And in this 2D simulation modeling, atrial fibrillation maintenance duration increases as fibrillator number increases. This is a mechanism of atrial remodeling proposed by Stanley Natel. As atrial fibrillation is maintained a more extended period, atrial electrophysiology becomes a shorter refractory period, slower conduction velocity, and larger atrial mass, vulnerable to continuous wave breaking. There is a concept of restitution in multiple wavelength theory. We know that action potential duration shortens as heart rate increases, and restitution is dynamic APD heterogeneity reflecting the AF wave break vulnerability. So APD changes higher degree at the exact change of diastole interval at the condition of a higher restitution curve slope. So this S-max is the maximum slope of APD restitution curve. As easy slope of S-max condition, ectopy converges to the restitution curve and recovers to the sinus rhythm. However, at the higher S-max condition, atrial ectopy cannot converge to restitution curve and eventually induce breakup of wavelets to fibrillation. Therefore, not only the static refractory period, but also dynamic heterogeneity of APD is another important factor for fibrillation. Okay, let me move to the focal source hypothesis. You can imagine tornado twister as a source of fibrillation in this theory. In 1960s and 80s, Krinsky and Winfrey reported there are the area of continuous rapid firing in VF map, and Gray and Khalife analyzed rabbit heart optical mapping VF electrograms and found the area with the highest frequency dominant frequency and called it moderator. Then why such a focal source of fibrillation shows disorganized irregular rhythm? Khalife proved the fibrillated conduction of a square wave by 3D computational modeling and spectrophotometer. And in the process of wavelet conduction from the focal source, regional partial conduction blocks make wavelets irregular and disorganized. Frequency analysis is the most commonly used mathematical method to localize focal source of fibrillation. And the classical method is fast Fourier transformation analysis, so-called FFT analysis for dominant frequency. In this K9 AF mapping study, dominant frequency locates in a specific area of left atrium, which drives the atrial fibrillation. Another mathematical method to trace the AF driver might be phase singularity. Because action potential amplitude has a cyclic pattern, you can plot the action potential amplitude at a specific timing on the x-axis and certain timing plus t on the y-axis, and it shows a cyclic pattern like a clock, and we call the angle from the center of this clock as phase. However, at this point, wavelet turning points, action potential amplitude change to be very low with ambiguous phase. So we call this point ambiguous phase as phase singularity point. In other words, phase singularity point match with spiral wave core of fibrillation. This is rhythmia map of relatively organized atrial fibrillation at the anterior mitral annulus area. You can appreciate 4 cores of reentries here, which is very similar to quatrefoil reentry reported in the optical mapping study. And this atrial fibrillation eventually terminated at this point during anterior wall linear ablation. Now let's switch gear to computation modeling for atrial fibrillation. The unmet needs of modern AF ablation are what can be added after PV isolation during AF catheter ablation in patients with persistent AFib. This is because almost all randomized clinical trials failed to prove the efficacy of empirical extra PV ablation, regardless of linear or electrogram-guided ablations. Therefore, I would like to introduce recent clinical trials of a focal source ablation during AF computational modeling. Dr. Trianov group developed the MRI lake gadolinium enhancement-based AF modeling to targeting the proper ablation of extra PV foci as a proof of concept study. And we previously conducted a randomized clinical trial with 118 patients with persistent AFib, and modeling guided linear ablation improved the ablation outcome compared with empirical ablation in 2017. However, we used a primitive monolayer homogeneous QBF prototype model, and simulation was conducted before the procedure with cardiac CT scan. However, the rapid improvement of computation technology, computation time for AF modeling has been reducing drastically. Now we can apply precision AF computation modeling with an electroanatomical map during the on-site AF catheter ablation procedure. Moreover, we developed and upgraded the target selection software, including dominant frequency, restitution, rotor, named the persistent rotation reentry, and we also developed the auto-detection algorithm for atrial wall thickness to overcome the limitation of a monolayer modeling of QBS system. Based on this advancement of computational technology, we conducted a prospective multi-center randomized clinical trial for computational modeling guided DF ablation in patients with persistent AFib. This is QBA AF tube RCT protocol using the computational modeling integrated by patient-specific voltage, conduction velocity, fibrosis, and fiber orientation. At the beginning of the procedure, we acquired the voltage map after restoring the sinus rhythm. And then we integrated clinical mapping data to AF modeling, induced the virtual atrial fibrillation, and localized dominant frequency. We can generate this dominant frequency map within 30 to 40 minutes during PV isolation procedure. So after PB isolation, modeling guided mapping information is given to the operator for the additional dominant frequency ablation. This is a synopsis of QBR and reflecting personalized anatomy, histology, and electrophysiology. At the beginning of persistent AF ablation, clinical team acquired the voltage activation map like this and send those EGM data to core lab, and core lab integrate the clinical map to AF modeling reflecting fiber orientation and fibrosis map. Then we induce virtual atrial fibrillation in the computer to localize dominant frequency area. It takes 30 to 40 minutes for computation. In this study, we included 222 patients with persistent AFib in QBR AF2 trial. Among the included patients, 23% were excluded due to failed cardioversion or reinitiation of atrial fibrillation. And the restoring sinus rhythm to acquire the electroanatomical map is a major limitation of this study. So overall, 170 patients were included and randomly assigned to virtual dominant frequency ablation group and empirical PB isolation groups. This is a patient characteristics. Two groups were well balanced, and 62% patient had the long-standing persistent AFib, mean LA diameter 45 millimeter, mean procedure time was 167 minutes, including computation and modeling time. These are the examples of the DF ablation protocol. In this virtual DF ablation case, DF site is localized inside the pulmonary vein, so we finished the procedure after PB isolation alone. In this virtual DF group case, with extra pulmonary vein dominant frequency, we conducted additional ablation to the dominant frequency site. This is an empirical ablation group case with extra pulmonary vein dominant frequency, but we did not touch those extra PV dominant frequency sites because it is assigned to empirical ablation group. This is the outcome of QBR AF2 trial. Computational modeling guided additional dominant frequency ablation showed significantly superior rhythm outcome than empirical ablation in patients with persistent AFib. We found the usefulness of dominant frequency targeted AF ablation. However, other parameters as a target for AF catheter ablation. We just published the QBR REGAP trial targeting the high SMAX sites. SMAX is a maximal slope of APD restitution curve, and restitution is a dynamic APD heterogeneity reflecting the AF wave break vulnerability. Depending on the atracellular characteristics, APD changes higher degree at the exact change of diastole interval at the condition of high SMAX. At high SMAX condition, atrial ectopy cannot converge to the restitution curve and eventually break up of wavelet to fibrillation. So the QBR REGAP targeted the high SMAX sites and its prospective multicenter randomized clinical trial that included 196 patients, and QBR REGAP targeted the highest 10% of SMAX sites instead of dominant frequency, and the modeling process was similar to QBR AF2. This is the rhythm outcome of QBR REGAP. Unlikely to dominant frequency ablation, SMAX targeted extra PB ablation did not improve the outcome of a persistent AFib ablation in this study. So SMAX reflects the wave break vulnerability, and dominant frequency stands for active AF drivers. Therefore, we evaluated the relationship between two different parameters by post-hoc analysis of QBR AF2, and we observed the consistent inverse relationship between SMAX and dominant frequency. DF targeted ablation showed a significantly better rhythm outcome at low SMAX condition than empirical ablation, but not at high SMAX condition. We are conducting another randomized clinical trial targeting extra PB phase singularity points, and you can appreciate AF termination during phase singularity ablation on anterior mitral valve annulus area in this specific example, and I hope we will be able to report the outcome of QBR PRR next year compared to sinus rhythm. The next step is the convergence of AI and CT integrated modeling data. To apply the atrial CT image to AI, we generated automated measurement of software for atrial wall thickness. By using this software, we can apply atrial CT imaging, including wall thickness, including human factors. So to calculate the thickness at the area with the folding, such as appendage, PV junction, we use the partial differential equation. Where we also developed a software for automated measurement for regional 10 segments of left atrium, and it shows excellent correlation between manual measurement and auto-region measurement. Next step is the applying 3D LA map on the AI convolutional neural network. By using multi-view CNN, we can train the morphology of left atrium by AI because our AF computation model QBIA is constructed based on CT imaging. We can train not only LA morphology, but also wall thickness, activation, voltage, dominant frequency, rotor, or restitution. These complicated AI calculations will be put together by ensemble model and eventually will predict clinically useful outcome data. I hope to show the outcome of multi-view CNN and the next year conference. So in conclusion, ladies and gentlemen, both multiple wavelet and focal source contribute to the mechanism of AF maintenance. Wavelengths, critical mass, and restitution contribute to AF wave break vulnerability. Dominant frequency and phase singularity are proven parameters reflecting focal source of atrial fibrillation drivers. The computational modeling guided virtual dominant frequency ablation improved the rhythm outcome of AF ablation in patients with persistent AFib. There is an inverse relationship between dominant frequency and Smax, and the dominant frequency at low Smax seems to be a real AF driver. Thank you very much for your attention.